PowerPoint jogging.
Yeah, I know. Mine's not technical, but I'm gonna be not so compassionate. There's a counter.
Of total time or each individual?
It counts down. It'll go 20 minutes, and it'll count down as you're doing it. And Jennifer, since we're so over, all of us are gonna.
We're going to pay attention to
We're not only gonna pay attention to it. We're all gonna try to go ahead of it, because if we all did our full 20 minutes, it would again run over.
Each of us should try to be done in 15 minutes. I will do my best.
See, yeah, and I think
Good morning, everybody.
It's not live.
It's not live.
Can we put
I
the
know.
mic
I don't know
on?
why it says that
Oh, it's on.
With
It's
it,
on.
with
Is
it
it on now?
kind of-
Okay, good morning, everybody.
Like that, I don't know why that's in there.
All those that need to
but
get
now we're
a
also
cup of
saying we wanna
coffee
try to
may
each
do
only
so.
take 15 because we're already 10 minutes
There's a
behind.
photo on the back of that, and the photo was up, and I was like,
I hope that all of you enjoyed yesterday's welcome reception, and those that were present past hour just had some good experiences with early diagnosis. I would like to introduce to you Dr. Shapiro. She's starting with neurocognitive functions, and I think I do not have to introduce her because she's world known. She's working at the University of Minnesota and working on LSDs for a very, very long time. Please, Dr. Shapiro.
Good morning, and I guess, yeah, is this live or not? I don't know. Can you hear me? Yeah, okay, great. So we're gonna rush, we're already about 10 minutes late, so we're going to rush through our slides this morning. And so you will notice that I'm not going to be talking about every single slide here, but just give it your attention, and I will try to give you a general overview of what it is that I want to convey to you this morning. So I'm going to talk first about neurocognition and in general. And so to give you sort of a general idea about what it is and why it's so important. So neurocognition includes many different areas of function, and they develop in a sequence in the infant, from sensory motor to learning to language to attention, and that really doesn't come into play until the child is a little bit older, and executive functions, which are those things that come into existence in adolescence, particularly like planning and organization and control of impulses. So this is a sequence that is generally related to age. And it parallels brain development. So you can see, for example, the beginning is really movement, and then it goes to language and social emotional, and finally cognition and learning. And so there's the same kind of parallel development of the brain and function. And there are three sources of abnormal cognitive function in MPS disorders. There are indirect effects where you have somatic involvement like hearing loss and poor motor function. Then you may also have learning difficulties in attenuated forms, and severe forms have really primary neurodegeneration that results in gradual cognitive decline. And as you can see on the right, the different MPS disorders have a different pattern of indirect function. For example, in MPS 3, we don't have very much somatic involvement, and in attenuated forms, we don't have neurodegeneration. So those are some of the differences. Whoops, I pushed the wrong button here. So getting back to the indirect cognitive effects, there's hearing loss, which affects language. There's motor delay, which affects motor skills and understanding of space. There's fatigue and physical illness that affects motivation and attention, and social limitations and physical differences that may affect development of appropriate emotional adjustment, particularly in adolescence. So learning difficulties that are stable are present in attenuated MPS 1, 2, and 7, and certainly in MPS 4 and 6. And learning difficulties affect the patient differently by age, depending on what the demands are. So there are different demands in preschool as there are in adolescence. And in many of these patients with MPS 3, the insulation of the nerve in the white matter is abnormal, which produces difficulties in paying attention, visual processing, and visual spatial ability. Now, neurodegeneration, which occurs only in the severe group, some of you have seen this slide before, and I hope I can get this to work. So what you see here is normal development, the effects of disease, and then a vector of the disease effect. And these children look pretty normal at the very beginning, but beginning maybe between 2 and 4, depending on, or 2 and 5, depending on the disease, you have a slowing of development, a plateauing, and then a decline in development. So this is really a plug for natural history studies, because without a knowledge of the rate of progression, you cannot do a clinical trial. You don't know what the normal rate of decline is for that disease, or what happens in that disease. And you need to gauge how long a trial will last by what the rate of decline might be. And parents need to know what to expect in order to better cope with these outcomes. So one other very important thing about natural history studies is that rare disease have a very limited pool of patients. And as all of you know, there are so many clinical trials going on right now, and there's a competition for these patients. And so I think that one of the things is that a natural history may diminish the need for multiple comparison groups. Another point is that these trials need to be international in order to get enough subjects. So for natural history and for clinical trials, there are a lot of challenges and guidelines for assessing cognitive development. You have to understand developmental issues. You must understand what is specific to the disease. You must know what tests are appropriate and what the challenges are for testing these children. And you need to verify results and do good quality control in all of these. Even in a clinical setting, you need to know if the data you're collecting is really valid for that child. And one way to do that is to get parent input on how they see the patient doing. So there are a number of lessons we have learned about neurocognitive testing. One is that one size doesn't fit all with respect to the cognitive profiles. Each phenotype has a different natural history. Each differs in rate of progression and needs a disease-specific approach. The second lesson we've learned is that the natural history of the untreated and treated patients differ for each disease and phenotype. Originally, we did systematic clinical observations, and now we have specific protocols to collect longitudinal data, and then you have a systematic collection of such data. I'm going to skip some of the details of this right now because we're really moving along. we need to move along. So accurate results, I will tell you for sure, depend on an experienced person who is familiar with both the test and the disease. Somebody who has never seen a child with MPS disorder comes in and does testing, they're not going to get valid results. They need to be trained, they need to know about the disease, what the limitations are, and they need to know the test like the back of their hand so that they don't have to keep referring to the test. So, for example, adapting a test for a child who has hearing or vision impairment or motor impairment. And you need to know what the limits are of that test, and whether the test is valid for that patient, whether it's for school programming or whether it's for a clinical trial. And a psychologist in a school or clinic who has never seen an MPS child before is not going to be able to get a really accurate estimate. They're often going to underestimate what that child can do. So one of the things that I want to emphasize is that the impact of disease on the brain occurs very early, probably prenatally, but we don't see that decline until later. So we know that in MPS I Hurler disease, it begins to slow in the beginning of the first year, in the end of the first year. In MPS III, the end of the second year. In MPS II, we know it's much more variable, and it can be anywhere from age 2 to age 5 that the child begins to slow and decline. Now we have newborn screening for MPS I, and so when a child is identified and confirmed, the challenge is to separate out those who are candidates for treatment with transplantation, for example, in Hurler syndrome, from those who need enzyme replacement therapy. And that is a really big challenge because we don't have a really accurate way of predicting which group, unless we know the mutation, and there are only a few mutations that we know are predictive. So we have an intermediate group that may or may not have severe disease. What do? You need to follow them closely with neurocognitive testing to determine whether they're declining or not. Moving on to the individual diseases. So Hurler syndrome, as most of you know, has documented poor outcomes for those particular mutations, the W402X or Q70X, or there are a few others as well. We know that those patients are going to have a poor outcome. They also have severe somatic disease, and they have the slowing at the end of the first year and decline by the end of the third year. And so earlier treatment for MPS I is better, and it's better for all diseases because you're going to avert brain damage in those patients. So one of the things that's really important is understanding the tests that you're using. So the original work that we did back in the 1990s used norm-based scores that had a floor of 50. So we really we underestimated the decline in untreated children because of this. And so we've developed other ways of adapting that outcome measure to detect the entire decline. And here's an example that was recently published to show this. This is with the 50 as the bottom. And here we have a new measure that is based on age equivalence divided by chronological age. And you see that that's a much steeper slope of decline. So why is this important? Because delayed treatment has a really negative effect on cognition. And in Hurler syndrome, every year delayed in treatment means a later 9-point lowering of IQ across all ages. MPS III is a disease that has less somatic symptoms, and so we have delayed diagnosis. It's characterized by progressive cognitive slowing starting in the second year, plateauing in the third and fourth, and declining in the fourth and fifth. And those diagnosed before age 6 are likely to be rapidly progressing. But some of them are not so rapidly progressing, and so you need to understand how those two groups separate. And some with delayed diagnosis are misdiagnosed with autism and other psychiatric problems because of the behavioral problems. Dr. Isengart will be talking about that a little bit later. So we needed to use age equivalent scores with MPS III. They provide information about slowing, lack of progress, and decline, and they reflect the observation of parents and healthcare providers, educators, and they make early identification easier. And this is a comparison of MPS III and MPS I. And what you can see here is this slowing of development beginning at about 2 and then not plateauing until about 46 months, and after 46 months they go down. And it's not so different than in Hurler syndrome. And none of them, and I want to point this out to you, without treatment, none of these patients progress beyond a 30-month level in cognitive development. This is MPS II, and MPS II is a real dilemma right now, because if you look at this as really the most recent publication regarding the natural history, and if you look at this, there's only one patient in this here who was followed for any length of time before the age of about 5. And so we don't have a lot of information about what we call inflection points are, when the child begins to plateau and when they decline. This is some old data that I replotted, and it basically tells the same story, that we really don't see too much decline before age 2, but we do see continuing development in some Hunter patients, and then a decline. So as I said, there's very little longitudinal prospective data. They apparently develop past 30 months, unlike MPS I and III, and the plateau may be quite long, and the age of decline may be more variable. MRI abnormalities are present equally between the attenuated and the severe patients, and so you can't distinguish that way. And mutation analysis is less helpful in identifying these two groups. And so we can't predict. And the other major problem with both MPS II and MPS III is behavioral difficulties overshadow the cognitive decline. And we need to, in tandem, look at both of these things and see whether the cognitive decline and the behavioral disorders, which come first. Probably they are simultaneous in onset. So there are a bunch of other very important issues, and I just want to briefly, I need to finish up here. Frequency of testing, frequent testing is okay over age 6. Practice effects limit testing to every 6 months. You have to do other domains. You need parent report through the Vineland is a really good example of a measure that provides information on day-to-day functioning in the family. Testing needs to be short, it needs to be focused, and it needs to be oriented to your goal, whether it's clinical or whether it's a clinical trial. I'm going to skip the neurocognitive testing in older children because we really can't do this right now. I'm going to move on, but I just want to show you some examples of MRIs This is an example of a MRI in a patient, same patient, moving from 4-year-old to 12-year-old. And you can see the atrophy in that patient's MRI. All of those black spaces in between are atrophy in that patient. MPS II, this looks like an awful MRI. It's got all these little holes in it and all of this, and this is a boy with an IQ of 128 and no cognitive abnormalities. So MRI is not a good predictor, at least what we can do right now of which form of MPS II we have. And we have a lot of information about early loss of gray matter in MPS III and cognitive decline, as you can see here, and white matter abnormalities in MPS I, but I want to move ahead and say that the goals for clinical trials are you need relevant sensitive measures associated with functional changes that caretakers and parents can connect to and that are familiar to testers and can be administered internationally. We need information relevant to parents and educators and that one can use for recommendation for interventions, and information to medical providers that is useful and can identify areas of concern. Thank you. Sorry. Night.
Thank you very much, Dr. Shapiro. The next speaker is sort of a younger generation, same place, same university.
I'll take that as long as I can get it.
Okay. Dr. Isengard is specializing on the natural history and neurocognitive endpoints of treatment of rare